Well, it's 8 o'clock. I wanted to say good evening to everyone on the web that's tuning in for uh, webinar series number 2 for the Fall Voice Meeting. Tonight, we're going to have a panel discussion talking about difficult cases that we may encounter in our multidisciplinary practices. I'd like to take the opportunity to introduce my panelists. With us tonight is Dr. Milan Amin, who is the director of the NYU Voice Center. We have Amanda Gillespie, who is at the UPMC Voice Center. We have Dr. Sunil Verma, who is the director of the UC Irvine Voice Center. And also, excuse me, we have Dr. Amanda Gillespie from UPMC. And then we also have Michelle Ledessa, from the Cleveland Clinic Voice Center. And for those of you who don't know me, I'm Paul Bryson. I'm a laryngologist, and I'm the director at the Cleveland Clinic Voice Center. So I also wanted to take the opportunity to plug the Fall Voice Meeting, which it's a great multidisciplinary meeting. This fall, it's going to be held in Washington, D.C. There is information at the website that's provided here on the slide, and it's important to note that early bird registration ends at the end of next month. And encourage you, if you're interested, to come. It's a lot of fun. There are panels and breakout sessions for both the laryngologists and the speech pathologists, and some joint sessions where we hope to have, and I know we'll have, good discussion. For those of you with residency training programs in otolaryngology, this is a great opportunity for residents that are interested in laryngology to come. There is a Laryngology Fellows Day and Early Career Laryngology Day. So the objective that I wanted to try to achieve here as we started this was to have a case-based discussion of some common complaints that are potentially complex to manage, and will typically involve the multidisciplinary team of the laryngologist and the speech language pathologist. We'll talk about our evaluation techniques. We'll talk about management strategies, things that perhaps work or that don't work, or perhaps things that work most of the time, but perhaps not for these case scenarios. And we'll proceed here to case number 1. I'm not seeing any of my moderators on my screen. I just want to make sure that everyone is here, and you know, I haven't done the webinar format before, so I just want to make sure everyone is with me, and if you want, we could just introduce ourselves and briefly just say hi, just so I know. There's Sunil Verma. Hello, sir. Amanda,
hi there.
I see you. Yes, hello.
Hello.
Hello. Milan and Michelle.
Hi.
Hi, great.
We're here.
Okay, everyone's here. Good. Well, then we will proceed. So I encourage you to submit your questions. Michelle's going to be fielding questions, and I will try to stop at different points during the presentation to try to answer some of your questions. If we don't get to your questions, they will be archived, and we will try to answer your questions after the webinar if possible. So without further ado, I will get into the first case because we do have a lot to cover. This case was provided by Dr. Amin from NYU, and this is a case of a 24-year-old male singer with a 6 to 7 year history of voice issues. Specifically, he reports that he often gets upper respiratory infections with a cough, and that it's associated with significant throat soreness and pain, with a significant impact on speaking and singing. He will complain of pain with singing, poor stamina with prolonged speaking and singing, and he reports a cycle that seems to be nearly constant throughout the year. And he'll only have several weeks between episodes where he is pain-free and feels like he is at peak vocal performance. He has seen many physicians who have treated the usual complaints, including postnasal drainage, and empirically treat laryngopharyngeal reflux without any improvement in his voice symptoms. And he's also attempted some things on his own, including voice rest without benefit. And in terms of his occupational voice use, he is a sales manager in retail, and he is a singer of Arabic and cantatorial styles of music. And I will have some voice samples of that for you later. So, no significant past medical history, no medications. His regular head and neck exam is normal. And on the screen, I've provided a few objective measures of his voice. And then I will play for you a voice sample here.
The blue spot is on the key again. We eat eggs every Easter. How hard did he hit him? My mama makes lemon muffins. We were away a year ago. Peter will keep at the peak.
Okay, and now I'll provide his exam. I'd encourage everyone to turn their sound up. It is a little bit quiet.
Get again for yours. Go like this. Watch me. Open your eyes. Like this. He. Switch over. You gotta come back forward again. Chin out. Hold it for as long as you can. Clear. Higher pitch. A little lower. Again, stay right there. Lower.
Okay, so I wanted to open it up to the panel. Amanda, what do you notice so far about this patient? What seems to be
So his speaking technique is not fantastic for somebody whose complaints are mainly in his singing voice. I'm kind of surprised actually, because his speaking technique, he's kind of dropping his airflow, trailing off at the end of sentences. I don't know if it's a way to maybe make him, he's like 22 or something, right? He's young. So I'm wondering if that's maybe a little bit of him trying to sound a little bit older, a little more, have a little bit more authority, but there's definitely something I think to work with in his speaking voice. And it could be that if he's using kind of a similar technique in his singing voice, that's just causing a lot of tension, tension in his neck, not great coordination between his breathing and his speaking, and that could be causing his problems. Because he's not really complaining he doesn't have a sound complaint, right? It's mostly a feel complaint. Is that, am I remembering that?
Yeah, Millen, what do you recall from this interaction?
Yeah, I mean, you're right. It's not a specific sound complaint, but rather really about the pain. And this is really sort of an interesting case because he, during a speaking voice, he has no real concerns at all. And he does have that sound, and we noticed that as well, that sort of sound that trails off a little bit. He uses a little bit of rasp in his voice, but he had no complaints at all. We asked him over and over again about a speaking voice, and it really is pain with singing. That's what brought him in, which is a very specific complaint.
Yeah.
And if you listen to him singing, and there'll be a clip later, he really does have quite a beautiful voice, and he's very successful actually in his world of cantorial singing in this Arabic style that he does, which is a fairly unique style as well. So it really was very specific to that singing issue.
On exam, Sunil, anything that you see on the exam, from the stroboscopy and the laryngoscopy that catches your eye or that you notice?
Yeah, I think initially I saw some muscle tension there. And then as the exam went on and you demonstrate some pitch changes, there looked to be a little bit of glottic incompetence. It was hard for me to tell if it's due to one side more than the other. But I would just say in general, that's something that concerns me.
I think that one thing that's fairly subtle that may be missed, because unfortunately the video was a little bit choppy at the end there, is that there was a little bit of vibratory asymmetry that was noted on those high pitches.
Yeah, I can try to go back and find that again for you. Let's try this real quick. I think it was a high. Well, you see it there a little bit, but I think it was higher.
Yeah, it's a little.
Lower. Lower. All right, so next, these are some of the things that Amanda touched on. And, from this part of the exam, he had pain in the tongue base and the thyrohyoid muscle area, or the thyrohyoid space. You mentioned the poor coordination of airflow and resonance with speech. So when we talk about a therapy evaluation, Michelle and Amanda, can you touch on these a little bit? What do you look for when you listen and when you get your hands on the patient? What else do you ask the patient, and where else? How do you like to do your neck exam when you're?
Yeah, I always see the patient in front of a mirror so that the patient, when I'm palpating them, can feel where I'm going and also see it. And then I can get very specific with that biofeedback from them. I prefer to have the ability to walk around the patient. Sometimes if we're in the actual strobe room, it's hard to do that, but I kind of wedge myself behind the chair. So from a palpation point of view, I try to palpate almost everybody to just check for baseline muscle tension. And then of course, the perceptual evaluation, as soon as they're walking into the room, I'm listening to their conversational voice, and then giving them tasks on the exam to hopefully reflect what the difficulty that they're having, and also letting them sing for a while if it's a vocalist, because they may be used to working around those things that are difficult. So we want to elicit them in the office in order to make sure that we can get an accurate assessment.
The other thing that I think is sometimes helpful is that if you can try a few therapy probes, like try doing some resonant voice or using a little bit more airflow, and actually record them while they're doing these kind of new voice techniques. And then you can play back for them, or even if you record it, if you have some aerodynamic equipment, you can play the whole file back for them and show them, when you first were speaking, did you notice X, Y, and Z about your voice? And here's something that we actually measured. And you can actually show them, when I had you do this resonance technique, we saw a change in your airflow, or did that feel different to you? Did it sound different to you? So they're starting right away to get this idea that they are actually able to change the way that they use their voice. And I think that's really helpful to see, to give me as a speech pathologist an idea of, is this someone who I think is going to do really well in therapy, or is this going to be like an uphill battle? You know, you get an idea of what their general awareness is of their voice. And I think that's really helpful moving forward.
And one other thing I'd like to add, I generally ask a lot of questions about singing training, singing load, you know, productive and non-productive voicing. What kind of voicing are they doing when they're singing? What singing style? Is it classical? Is it mixed belt? This sounds like a traditional cantorial style. So I would be kind of feeling out all the different ways they're using their voice. So not just, you know, the short duration of what we're hearing, kind of seeing the whole vocal load.
So Millen, what options did you present to the patient, and what did he seem to be most inclined to go for?
So just to step back 1 second, you know, I think that part of the issue was this very specific pain with singing, which, you know, as you know, is not such a normal thing that you see, especially in somebody who does, in fact, he's in sales as well, and he speaks all day, and he has no pain with speaking. And so I wasn't so concerned necessarily that this was a speaking issue that required, you know, intensive voice therapy up front. And I was a bit concerned, you know, when we talk about pain, there's only a handful of things, in my opinion, that really, that I see that come out of patients who have odynophonia. Those are, you know, for example, granulomas, vocal process granulomas will cause pain. He clearly doesn't have one. Obviously cancer, we want to rule that out. We look around, we don't see all that much from this perspective. And then the two other things that I see are glottal insufficiency, which can lead to muscle type pain from strain, and sometimes a subtle scar that will do the same thing, essentially result in muscle tension, result in straining, which will then lead to sort of the muscle type pain or soft tissue pain from the strain on the soft tissues. And so what concerned me really was the appearance of the vibratory asymmetry, which made me think that maybe this is a glottal insufficiency issue, perhaps a scar issue. And so I offered him really two approaches. One was to go into the traditional voice therapy and work on muscle tension issues, and the other one being going to the operating room and evaluating those vocal folds better and doing a trial vocal fold augmentation.
And then so that's what we did. That's what you did. So we have some intraoperative photos now. So it seems that he wanted to go with the augmentation in this regard.
He did, yeah.
Okay. So when you talked about an evaluation under anesthesia, so you know, what do you like to do under anesthesia aside from the injection? We'll get into some of the details about that and ask Sunil what he does as well. What's your sort of approach when you go to the OR for this?
Yeah, I mean, essentially what we're looking for is pathology that's hidden that we couldn't see all that well on stroboscopy or was hinted at on stroboscopy. Yeah. So you have the ability under anesthesia to palpate the vocal folds, look on the undersurface of the vocal folds, which is not easily evaluated on stroboscopy. You can get hints of it, but you don't see it all that well. And oftentimes you'll see atrophy that you weren't able to see all that well on a static exam or an exam through the nasal cavity, oral cavity, and you'll be able to look into the ventricles a little bit, things along those lines.
Okay. And Sunil, you know, there's definitely practices around the country where people will suspect that there's a side that's weak, or you know, people will talk about a paresis. Is there any role in your practice for laryngeal EMG, you know, prior to going to the operating room?
I think, Paul, that's a good question. I think it can be a nice adjunct, but it isn't necessarily going to change my decision making. So I think it's based on the patient's preference as to whether or not they really want to go through with it. I think some of them, when described it, maybe aren't as eager to go through with it.
And so any role for if you see a sulcus or things like that, are there any other things that you do to the vocal folds aside from the augmentation? People talk about saline infusions and things like that to look at the topography of the cord.
Right. So I think the use of just to go off more on what Millen said, I think using angle telescopes helps with evaluating the undersurface and medial aspects of the vocal folds. Injection into superficially to determine how the epithelium lifts up. And depending on that, maybe therapeutically injecting with some steroid perhaps, or even a little bit of filler there. And I'm curious, Millen, what did you see on the vocal folds there?
So you can kind of get a sense of it here in these images. There is a subtle area of sulcus actually present on that left true vocal fold. And Paul, maybe you can point that out right there. And I think on the closer up image, you can see it a little bit better. And it was not a deep sulcus. It was probably a type 1 sulcus. And after injection, it became even a little bit more obvious that that area didn't elevate all that well. There was some retraction or some inability to elevate that fully. And it wasn't major, but it was definitely there.
It appears that you not only injected that superficially, but then also did deeper injections bilaterally.
No, I didn't inject superficially. They're just deep injections, and that's how sort of the appearance came out.
Got it.
What's your injectable of choice? I'll ask both of you. What do you like to do for these trials of augmentation?
Mine is based upon location, really. I think the OR in our instance talks voice gel, or I guess what's it called now, Berlerin gel, and in the office we use Restylane.
Okay.
Similar, we tend to use Juvederm, but a high hyaluronic acid.
I'm the same. I use mostly Restylane, but it uses other products as well. I want to stop for some questions, but I do have a couple other questions. There's been some, discussion, probably amongst ourselves, but also in the literature about using these trials of injection as a predictor for eventual response to a more formal medialization. Sunil and Neil, what's your take on that? Is that something that you feel is generally accurate, or can you reproduce it later if they like?
I'll be honest with you, I don't tend to. I tend to go more so to the Juvederm or to some hyaluronic acid, not much of a trial. Short-term injectable.
Yeah, we're having trouble hearing your audio a little bit.
Go ahead. Then I'll ask Millen that then. Sorry.
Yeah, no problem. Yeah, so Millen, do you feel that the injection is a good proxy for what you might get out of a more formal medialization down the road?
No, I think there's a lot of variability. There is, in some cases, you'll get a very accurate response. In other cases, you won't necessarily see it. I think that there are several issues that are related to that. I think it has something to do with where the injectable goes, but I do think that patients oftentimes there's not enough time to really work through some of the issues when it comes to an injectable, especially if you're using something like a Berlerin gel, which doesn't last all that long.
Right. Well, let's hit the pause button for a second and answer some questions from the web. I understand there's some questions.
Yeah, there's questions that came up. The first is, do we have any preoperative singing samples? Or do we have any samples from when he came in the office of singing?
I don't believe that we do. Millen, it's more of the pain with singing as opposed to an actual sound effect that he was bothered by. Is that right?
Yeah, it's true. I mean, we probably do. I didn't put it in the presentation because, again, this was more about pain than it was about the actual singing.
Okay, so let's ask, we have a couple of really good ones here. So John Paul Giliberto asks, what are the panel's thoughts on the most reliable findings on video stroboscopy suggestive of paresis?
That's a good question. we look, I mean, I think we'll all have some similar criteria. I tend to look at, I tend to look at the false chords and the compression. I like to look at asymmetry of vibration, like Millen and Sunil mentioned. That said, I don't know that we're the best predictors of it. I think there's been certainly some papers out there that the EMG, when you do it, tells you that you might be wrong. So those are my, my thoughts on the matter, but I'd love to hear everyone else's thoughts as well.
Well, I also just want to add that just because there might be some asymmetry doesn't actually mean that it's pathologic or contributing to the problem. So I think sometimes
that's a very important point.
We have no idea what normal asymmetry is. And so I think that if we start to assume that something that might look a little bit different from textbook is the cause of the person's problem, I think we run the risk of starting to sort of bark up the wrong tree when it might be something much simpler.
Okay, I have a couple of other questions. How did Dr. Amin decide to go to the OR first and not do an in-office procedure?
That's a great question. I think that the decision to do in-office injections versus operating room injections really boils down to what you think the pathology is. I think in this particular instance, if I thought it was just purely an atrophic vocal fold, I may decide to do that in the office. This guy had a particular complaint of pain, and with that asymmetry, I wanted to characterize that a little bit more. As I said, in the beginning, that pain is very particular to something, and I of course want to rule out anything bad, but certainly we will oftentimes see cases of scar or sulcus that you will only capture if you're doing it in an operative venue, and you will not necessarily see it if you're doing an office injection. So I wanted to get a good diagnosis.
And then another anonymous attendee asked, why didn't you start with voice therapy as a first approach?
It's a very reasonable approach as well. We offered both. I think because of his complaints, very specifically his singing, he didn't feel that voice therapy itself would address his particular issue. And we did actually talk to him about singing instruction as well, but obviously that is a cost issue out of pocket for him.
Okay, and then this is a particularly interesting comment, and I think it hits on something that's really important to this case. And this is from, pardon me if I pronounced your name wrong, I do my best. Izdebski asks, or basically it's a comment, but Arabic singing is different from English speech. Singing is a pentachord type with quarter tones. His speaking voice was okay. Singing was airy. Typical pain stems from muscle fatigue. And then he wants to know the result of the injection. But I think that the style of music was an interesting point to bring up.
Well, yeah, so good. So I'm going to keep moving on. I want to make sure we have time for our second case as well. So without further ado, let's see here. Hold on one second. My presentation seems to have paused. Okay, hold on one second. Okay. Okay. All right, here we go. Here's the post-op. Sorry for the delay.
Less strain, a little lighter. Good. This here. This here. There you go. Yeah, lighter. Go high now. Or vibrate up here. Make this vibrate. Okay, how about just an E? E. Yeah, just have some higher. Yep. Single. No. Where?
Sorry about that. Okay, and here we have the voice sample.
The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
Sustain your voice on a long.
Oh.
How do you make the sound edge?
Took the subway. Walked a lot.
Okay, so tell me
I-
where you separate from.
Okay, so I live on 59th and 6th. And I walked from 59th and 6th to right in front of where Bloomingdale's is. Take the 6th train, which is 59th and Lex. And then I got off at 33rd. But I was debating on getting off at 42nd. I wasn't sure which was closer.
Okay, so what how did he like this? What were his thoughts? I know what happens next because I have the presentation, but what were his thoughts on how this all went, and did you achieve what you had hoped to achieve?
So I think that if you listen to his speaking voice, the answer is no. He clearly still has that rasp to him, that the gravel to his voice. I think he actually felt there was some improvement in his overall stamina, those types of things, and so it sort of achieved it. But clearly, it wasn't a home run from my perspective from looking at that video.
So at that point, you had gone to, we did the full court with voice therapy now, correct? And so here we can see some of the different things that he used to try to enhance what he had gotten out of the injection. So Amanda, when you look at this list of things, what any comments, any things that you would add? And then I'll ask you and Michelle both sort of on some strategies for carryover.
So I wanted him actually at this point to have some really targeted singing voice therapy. It looks like this is mostly working on his speaking voice technique. And I think that his complaints were so specifically with his singing voice. I mean, I can pick apart his speaking voice all day, but he doesn't care, so I'll get over it. And so if his problems are really with his singing voice, working on very specifically where in the music that he has to sing for his job, where is he having those problems? Because maybe that's where some of this kind of funky tension is coming in. And now he's got new anatomy. He has, since having the augmentation, and just to help him navigate that with his singing voice is probably where I would have directed this a bit more.
Okay. And so Michelle, I'll let you chime in here. So he's real quick. I'll go back. So post-treatment, he felt more in control, although he still had tension, strain in the extremes of his range. So he felt like it was beneficial, but the singing was still difficult, and obviously projection and things like that. So here we are again, and let me just see here. Okay. So let's see. So here we are, sort of post-therapy, post-injection. Trying to get the volume up as loud as we can here. Okay. So Millen, now what?
So, I mean, at this point, basically, his augmentation has worn off. It's a very short-acting injectable, and I think he had come back essentially with this complaint saying that he had improvement and then he lost that improvement. I think on that video you can see much more clearly that thing that we were looking at, which was that anterior sort of gap. It almost looks like a little bit of a cutout or wedge anteriorly that he's not able to close all that well. And I think that's essentially where the sulcus lesion was. And so we did talk about going forward and continuing with doing more therapy, or considering doing something more permanent like a bilateral medialization laryngoplasty. And it's not that I thought that that was the definite way to go, but I was introducing it as a potential measure going forward. I still did think that he would do well with some further therapy. More, as Amanda said, more toward the singing aspect. Now, again, there's a cost issue associated with that, and I think he was wary of that. And we did get him a couple of lessons, but it was hard to continue that.
It seems like it's often difficult to find sort of targeted singing voice therapy in our communities. I would say I suspect the access to it might be a little bit better in the city, but the cost would probably still be an issue. I certainly know in the Cleveland area, it's hard to find specific people that you trust and that you can sort of engage in. The next one. So it sounds like made some improvements. At least enough evidence to try to do a bit more, and then he went away as they sometimes do, but came back. So when he came back this time, Millen was where was he at? I mean, a couple years had passed, and was it pretty easy to get back into where you sort of left off from, or did you feel like you had to start over a bit?
No, I think it was pretty easy. This was one of those cases where there was not a lot that I really wanted to do. Here's a singer who is fairly successful, getting gigs. He's a pretty popular guy. I didn't really want to mess with his vocal cords all that much, to be honest. And so, I was more inclined to having him continue along the therapy aspect. He kept asking for, what else can be done. I mentioned this bilateral medialization laryngoplasty, but even I was not all into that. I didn't really want to do it all that much. I thought that, it was an option, of course, because he did have some improvement, but it was more than just about the surgical manipulation of his vocal folds. And so I presented it as an option, and eventually he just, kept asking me questions, came back, and eventually decided to go forward with it, with the caveat being that we may or may not solve his problem, but that we know that the augmentation did do something for him. And so we underwent the procedure, it was August of last year.
Okay. And for Sunil and for you, how often do you do bilateral versus unilateral? So you had sort of identified an area on the one vocal fold with the sulcus, had a vibratory asymmetry. What's your thought process with unilateral versus bilateral? Sometimes it's a hard call.
Well, I tend to do bilateral injection laryngoplasty more often than bilateral thyroplasty or medialization laryngoplasty. So I think when safely done, I don't think there's too much of a risk, but I think that there's, at least with me, there can be some variability, and I'd rather stage it at times, depending on exactly what the complaint is. I applaud you for doing this, Millen, because this is a high level performer with who's otherwise doing pretty well. So good job.
Millen, what are your thoughts on unilateral versus bilateral?
I laugh because the job's not done, obviously, but no. So I tend to do bilaterals actually on these. I do think that it's hard for me oftentimes to determine what side the problem is in these kinds of cases, and I don't know that it's all that important. I think it's important that you get closure, and for me, I don't know that matters which side I get closure from, and so yeah, I don't really have an issue oftentimes doing these bilateral ones. I think it's actually sometimes more helpful, to be honest.
Mm-hmm. Well, let's play the voice sample. This is post, and we'll get some singing
The
finally.
blue
I know we have
spot
some
is
people
on the
wanting to
key
hear.
again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak. Okay. I walked over to the subway, and then I got out of the subway and walked over here.
I lied. The singing comes later. Here's what the strobe looks like. Looks like a pretty nice medialization. Okay. So this was afterwards. Okay. Amanda and Michelle, what are your thoughts on how he sounds afterwards, and what are some of the things after, Amanda, after you had sort of mentioned that you sort of changed the equipment a little bit after an injection or a medialization? How hard is that transition after something like this for folks?
I don't think actually all that difficult. I would say that my approach to therapy would be more how are they using their equipment, not so much what it is. So, regardless of what the type of surgical intervention was, if a person is using their voice in such a way where they have excess tension, then that's where you need to be working. If they're, whatever the kind of funny technique that they might have developed as an adaptation to the surgery, if they've developed any, then that's what you want to address. And sometimes there's a little bit of an effort trade-off. Sometimes people have to use a little bit more cognitive or physical effort in their speaking voice to get them a better sound, but then you can kind of show them that there's times when they can back off of the effort, and when their voice isn't quite as important to them. It all kind of depends on what they're doing after their surgery.
Okay. So here, let me just see here. Let's do this. Here, we'll get to hear some singing now.
جددت حبك ليه 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 بعد الفؤاد مرتاح جددت حبك ليه 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 بعد
after all of this, Millen, where was he at with, after this? How did it feel? Where did he think he was?
So interesting enough, he actually happened to walk in the office today, and so he's several months out, and so we chatted a little bit about this. His pain is completely gone, and he's actually feels like he's much better. Oddly, his upper range has really strengthened. His power has definitely increased, but he feels that his lower pitch range has dropped somewhat. Like his bottom has fallen out a little bit. And I still don't quite know why that is. I don't think it's really from the medialization, but if you look back at some of the videos, where he struggles functionally is at the lower pitch range. He really flips his supraglottis when he drops his pitch, and I think that's where we really need to work on. So we talked again today about going back and working with a singing voice specialist, and he's hesitant, but I think we're pushing him really hard to do that at this point, because I think that's the only thing that really is remaining. But overall, he's quite happy with it.
Okay. Yeah, that's a tough one.
It's a tough case. I mean, there's definitely no answer here. I think that one of the reasons why I thought this would be interesting is that there's so many aspects of this. It's hard to go over in the time allotment that we have.
Well, since it's difficult cases, we want to definitely do plural cases. Let's take one, maybe two questions from the audience, and then we're going to dive into our second case so that we make sure we cover some additional ground.
Okay. There was a question about whether the SLP corresponded with his voice teacher, but I just wanted to clarify that you said that he wasn't currently studying with anybody. Is that right?
No, he did not. In fact, we were asking him today, what have you been doing? And he's sort of, well, I have a guy who, I play piano with, who's working with me. And we just said that that's just not going to work for you. Yeah. And so we do have a person in-house that does work with a lot of our folks, and we're going to hook him up with him.
And then maybe one last question. I think this is a good one for the panel. How do you handle when you and the patient have very different ideas about what type of treatment to try next? Do you insist? Do you yield? Do you say no way? What is your approach to patient decision making?
I can answer for myself. I think it's all of the above, really. I think there are cases in which I insist. Less so, I think. I think there are many more cases in which I will yield to the patient's interest, typically if they don't want anything done. And in many instances, I will say that, look, I'm not going to be directed by what you want if it's the wrong thing to do.
Sunil, what are your thoughts?
I agree with that. I think I'm much less influenced to perform surgery if I don't feel like it's going to help. They may read about something online or ask that a special laser is used or something of that nature. But I insist, a lot of times patients want to go straight to surgery, and I insist on therapy or medical management first. People often want quick fixes for obvious reasons, but it's not always possible.
I think the hard thing about trying to force, quote unquote, someone into voice therapy is if they're not motivated, if they don't want to do it, they're not going to get better. I mean, they have to, voice therapy is what, 30 or 45 minutes or something once a week, and you can teach them a lot of great things, but if they don't take what you teach them in that therapy room and actually use it when they leave the room, then they're never going to get better. So it's hard to tell someone, you have to go to therapy, because, I mean, then they're just wasting their time, and they're wasting your time too.
So that's a great, I'm so glad you brought that up, because that's a lesson that I've learned over the years, really, is that, oftentimes you'll send patients to voice therapy because you're like, oh, well, it's non-invasive, what's the big deal? And the therapist will come back to you like, what are you doing to me, right? Because you're wasting my time, and my slots are getting filled with people who are not going to do well with this. And so I think that, even though I think generally we like to think of non-invasive versus invasive, you saw in this case that I actually went a different direction, went to the invasive direction, because I didn't think that the patient would do all that well with voice therapy. And we had an assessment to sort of discuss that, but that's the direction I went in this case.
All right. We'll get on to case number 2. This is provided courtesy of Dr. Gillespie at the University of Pittsburgh. and it is a question of vocal atrophy. This is a 67-year-old male professor in a very vocally demanding job. After talking with Amanda, this person is certainly a vocal professional, uses his voice not just for teaching, but for obtaining grants and funding and actually, quite lucrative funding for his profession and research. Here we have, his initial assessment. Amanda, do you want to? You kindly provided some open-ended things, so this is nice. You can sort of fill in the gaps with, his personality. What share with the audience, sort of his.
Yeah, so this is a really, like you mentioned, very professional, wants answers. He's a very mechanistic person by profession and personality. So really interested in, what am I doing? What do you see? How do I make this happen? So here's his initial, all the battery of questionnaires that we kill people with when they walk in the door. So the HI-10, the RSI, DI, CSI, the EAT-10, they're all elevated, which is always, I think, a little bit interesting when somebody comes in and has like an EAT-10 of 14 is really high. I think normal is under 3. So that's always a little bit of a red flag that maybe this is someone who is just feeling incredibly symptomatic, sort of across the board.
Yeah. Yes, Sunil, what do you like to get when you see new patients? How do you combat survey fatigue?
That's a great question. So we try and target it towards what their complaints are. So if they don't have too many swallowing problems, I try to hold them back from that. I will say for a lot of the questionnaires, even though you may not look at the numbers, it helps direct the patient's complaints to you. So they may come in with just some global complaints about their throat, say it's a dysphagia case. But after going through the E10, they'll often say, well, that one question is really what my problem is. And it helps direct them. So I think that's very nice.
All right. So here's some more additional evaluation from his first visit. And out of this sort of thing, what do you find the most clinically relevant, Amanda and Michelle? I could probably we could collect more data, but out of this battery, anything come to mind for this patient? We'll play the voice sample here for a minute, but.
I think I'm always interested in vocal effort. I know that's subjective, but ultimately the patient is the judge of their own voice. So for me, I like that patient assessment of vocal effort, and that's something I often ask patients to rate at every session. So that it's always how they're reflecting on their own voice. That's very valuable, I think.
Also, you can start answering the question kind of like we talked about with the last case, is this a sound complaint or a feel complaint? Because sometimes that leads you in very different directions diagnostically, but also therapeutically when you're thinking of how you're going to target the complaint. So, I think in general, a 3 out of 10 is relatively low effort for someone who is perceptually has a relatively, moderate to severe sounding voice, at least based on this overall severity measure. Also his, the CSID is the Capsular Spectral Index of Dysphonia. It's a time and frequency based acoustic measure. And a CSID of 62 is high. So these numbers are outside of normal. But I think for his age, his aerodynamic information is relatively normal.
Okay. Well, I'm going to move through this just a little bit, just because I can't believe that the hour is approaching. So stimulability, I find this interesting. So he had dysphonic vegetative sounds. He was not stimulable to voice probes. And, can you tell the audience just a little bit, what are your vegetative sounds? What do you like to check for stimulability? And then how frequently does stimulability lead to a therapeutic response and vice versa?
Yeah, good question. I don't really have a vegetative sound battery, but just as you're listening to people, if they clear their throat and it's this, and they get this really nice clear, but the rest of their voice sounds very dysphonic. That kind of tells you like, oh, maybe there's something in there. If their laugh sounds dysphonic or not, just the kind of sounds they're making when they don't realize they're making sounds. And he was dysphonic all the time. And the other, in terms of therapy probes, what I wrote here is pretty much what I would try with everybody. So a little bit of resonance, and I'm listening, do I hear a change in their voice? I'm asking the patient, do you hear a change in your voice? And then also, do you have a change in the feel of your voice? Because sometimes they'll say, oh, it sounds the same, but oh man, that felt a lot better. Or no, it feels exactly the same, but I could hear that it was more clear. And so I'll just go through a series of voice therapy techniques, just kind of small, isolated. It doesn't take more than maybe 5 minutes just to hit on a couple of things, just to start helping my awareness of, is this someone who can change their voice in response to some kind of cue? And it also starts to give the patient an idea of if they can or cannot change their voice. The best case scenario is you get someone who gets a better voice right there in your voice lab, and you can say like, okay, I think that if we actually had more time and you wanted, we could work out some voice therapy, we really could make a difference, because you're already hearing that you can sound better with just using a couple of these techniques. So I think it's super helpful with patient self-efficacy, which helps keep them in voice therapy, and then they're more likely to do better. In terms of like what percentage of the time is your stimulability probe accurate, I don't know. I'm not sure.
I'm sure somebody's looked at it. I just don't know.
Yeah, it's interesting. We did a study looking at, are people stimulable? And we kind of just looked across the board at different patients and found that to help identify the best techniques to use in terms of stimulability prompts in Voice Lab, but how that actually correlates to voice therapy outcome, we don't know.
Okay. All right. Well, let's keep moving forward here. So here's what he sounds like.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light to many beautiful colors.
And just for the sake of the camera here, can you tell us a little bit about your history again? This was a fairly sudden onset 2 years ago.
Sudden onset 2 years ago, related to a cold that then recovered somewhat. After that, it probably had sort of a very gradual decline.
Okay. And your chief complaints in your own words?
The inability to, raspiness in the voice, and the inability to speak at a projection volume.
Go back and forth between a sniff and an E, so it sounds like this. E, E,
E, E, E, E.
Good.
E.
You say we eat eggs every Easter.
We eat eggs every Easter.
We were away a year ago.
We were away a year ago.
Good. Breathe. Make it a breathy. Good. Breathe.
Okay. Well, Sunil, what do you think so far?
Well, I think cheated by showing that slide. I agree. There's some element of muscle tension there. I'm not quite sure where the atrophy is. It's a little difficult to discern.
Yeah. Yeah. It seems. This is one of those instances where it seems, with a high-level speaker, it might be easier to sort of tack to, a therapeutic approach, even though the stimulability wasn't great. So it seems that that's what was done, and a couple sessions working on resonance, loud voice, conversational training therapy. Unfortunately, not making progress. He's eating better, so we can say that from the EAT 10, but still not there. So here's what he sounds like.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Well, tell me how you're doing since we saw you last. Are you better, worse, the same?
I'm attending more to voice, and when I attend to it, I can enunciate better. Other than that, about the same.
All right. He's holding on tight. So, what's next? What are some thoughts, Sunil? Where would you sort of go from here?
You know, this is pretty difficult to. Are you having trouble with my audio? I think I'm going to bow out because I think my audio's not working.
I think it's better. I can hear you fine.
Okay. So I guess if we're considering this being a vocal fold atrophy case, this is potentially a role for a trial vocal fold injection, and to see how that would go. So we'd want to time that with a period where he is not having a too vocally demanding of a job. It sounds like he's needs his voice quite a bit. So I think that would be one possible option for him.
Okay. Yeah, and in the interest of time, that's what was done. And Amanda, do you know, was it one side or both? I didn't gather that from the.
I don't know. Sorry. I'm going to default and say probably both. But I'm sure in about 30 seconds I'm going to get a text message telling me what the right answer is. I don't know. Sorry.
Did he have a laryngeal EMG? I know that you have a little higher volume of EMG.
No, he didn't. He did not have EMG.
Okay. All right. So he had an injection. He's getting so close to eating without complaints. But yes, still with difficulty here. A little bit better on the VHI, but about the same. And here we'll get to how he sounds now.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
So you had a vocal cord injection in early June.
June 2nd, I believe.
Right. So how have you been doing since?
It was substantially worse for a week, then improved. I don't think it ever got quite as good as it was before.
Okay. So what's bothering you about your voice right now?
Voice tone, the ability to speak without the low frequency rasp.
Breathe. A little lower pitch sound. 120. 20. And now another. Good. Top it a little lower. There you go. Good.
Okay. So at this point, definitely frustrating and difficult. So we head back to back to voice therapy here to see if we can have a breakthrough. One session so far. Where Amanda, like you said, what else?
Right. I think that's really frustrating.
Oh yeah, these are hard. Anybody else on the panel have any thoughts? Millen, Michelle, any questions?
My thought is when you have the wrong level coming together and you want the right level to come together, meaning true versus false vocal folds. I think that when I see a patient like this, I think about powering up the voice and really trying to just get those chords together. But then you have to balance that with unloading and making sure that the patient is supporting the voice well and opening up the pharynx. it's definitely that tricky picture of tension, but also insufficiency. But I just wonder if something with a little bit more meat to it, maybe a little bit more of a robust kind of therapy protocol. And then one of the questions on here, there's a couple of interesting questions. Would you like me to go ahead and read them, or you want to?
Yeah, well, yeah, we're unfortunately nearing the end, but we should take some more questions. So why don't we? Yeah, let's go ahead and take a few questions and.
Okay. So let's go. There was a question about whether this patient could have like a possible dystonia. Was that ever brought up?
No. Are you thinking like an SD?
The person says needs to be tested for possible dystonia.
Okay. No, I mean, we hadn't thought about that.
Okay.
So I'll just add to that. That was going to be my comment. Is there are some patients who have that sort of low-level, raspy, sort of gravelly voice that they can never get out of. That can be a dystonia as well. You usually don't see that strong false chord squeeze with it, but a lot of folks will have a low-level dystonia that they'll try to compensate for, and they'll develop a muscle tension on top of that. It's a consideration, I think.
Is there any role for just a trial of Botox? I know the stakes are high for this person, but maybe at the right time.
We have done that, yeah.
So I will say that there are times it may seem like augmenting and using Botox seem to be contradictory to one another, but we have used that and found some success with individuals, and that would be, if we've gone through therapy and not seen the success that we want, there's very little risk to it. I mean, it is a 3-month trial. But you'd be surprised if you expand who you want to include Botox for, where you'll find success with that. And I would start off at a low dosage on those individuals.
What other questions? That was great.
So I'm getting a couple of questions along the same line, so I'll ask the most recent one, which was there any exuberant, I like that choice of words, voice therapy done like Forte for a month to see if the respiratory and phonatory coordination reduced the hyperfunction and improved the glottic competence?
So that's actually the first thing that we did. So the first thing we did was sort of like a Forte-esque therapy. And actually what we started working on now with using an EMST device to help to really energize his respiratory system to see if we increase respiratory drive, will it actually help his vocal fold vibration, so he doesn't maybe need as much of that supraglottic squeeze. So actually alternating back and forth between doing this high respiratory drive EMST treatment with also some SOVT, just to try to unload the system and get kind of the most efficient output. He always sounds exactly the same. I mean, there's no change regardless. So it's hence the reason it's brought to the panel. It's frustrating. But yeah, it's a great suggestion. I think that this idea of helping people to get loud, helping to kind of balance the respiratory and phonatory system and really energize is a great idea, especially with aging voice.
What other questions do you have there, Michelle? We're nearing the end, but I want to make sure we get some in there.
Some of the questions, somebody asked if you tried circumlaryngeal massage with this patient.
Sorry. No, I didn't. He actually doesn't have any feel complaints of tension. It's not his problem is not, he's not, obviously we see that he's visibly tight, but yeah, he's not actually complaining of any of that. So we didn't try that.
Yeah, and I have a couple other people questioning dystonia as well. Yeah.
Okay, I think we have time for one more, and then I think we'll conclude this webinar. So if you have one more, we can take it. Otherwise, I'll start wrapping it up.
Another question?
Yep.
Oh, okay. Let's see. Let me go back here. Okay, this is a question about rationale to do injections. So I'm hearing a rationale to do injections because the client uses the voice as at a level as a vocation. If the client uses voice as an avocation, not as a vocation, would you still consider injections?
I guess for me it really just depends on on how bothered the patient is with their voice, regardless of how you use it. You just sort of listen, listen to the patient. This is one of those things where the history and what they have on their agenda sort of drives the aggressiveness or otherwise of the treatment approach.
Great.
Okay. Well, I just want to thank my panelists, Dr. Verma, Dr. Amin, Dr. Gillespie, Michelle Odessa, and I want to thank Allison Conley for helping with the behind the scenes work with this webinar series and the Fall Voice Conference in general. I'd really encourage interested participants and audience members to consider coming to the meeting. I think you'll find it fun and enriching. So we'll try to answer further questions that'll be banked, and this webinar will be archived for future reference. So thanks again for the opportunity to present this material to you tonight, and I hope you have a good rest of the week.